Thank you, Esther. Let me open it up to the committee for questions. Any comments? Let me open it up more broadly while the committee gets its head organized. Dr. Wu.
Sorry about that. Thanks very much. I thought you gave a very comprehensive and actually really easy to follow presentation, given the complexity of the topic. One sort of possibility is measuring, sort of failures or adverse outcomes. You haven't said so much about that in your outline. Can you comment? It's particularly relevant, of course, for healthcare.
Yes, absolutely. And that's kind of lumped under quality of patient care. And, you can dispute which outcomes really fall under which category. I don't think that's highly relevant. As I mentioned in the beginning, the model just allows me to sort of bucket those outcomes. So for us, these are kind of quality of care indicators. And what's measured in our organization is our adverse events like falls, like pressure ulcers, pneumonia, and urinary tract infections. Basically those standard things in acute care. I think we have heard from primary care, we have other indicators like ambulatory care sensitive indicators that we can use to that effect. So I do feel the system that we have in place is actually quite well suited to measure these kind of outcomes. For me, these are kind of preliminary indicators to the ultimate patient outcomes. They really speak to how, some people argue that a lot of these errors happen because of poor communication, because of poor coordination. So for me, they really speak to the quality of patient care level.
I think that makes a lot of sense. It seems to me there might be some IP collaborative sensitive bad outcomes in particular. I don't know if you've sort of tried to think that through at all, but it seems like it could be fruitful. At least you can draw a straighter line between, sort of what wasn't done or what was done or not done. And I really like your idea of measuring those behaviors and then maybe the occurrence of those outcomes. I don't know if anyone else has any thoughts about that also.
Well, I can give you one example, for example, pressure ulcers. What we have found is that quite often, they don't come overnight. They start with red spots, and quite often, it's the healthcare aide that makes the observation, but somehow there is poor communication between the different levels of providers, and so that does not get communicated early on that people could take remedial action or being proactive in terms of how to approach that. And we have found from our interviews that quite often the healthcare aides do not feel like they're part of the team. There's strong hierarchies within the system. They don't feel comfortable talking to the leads, RNs, or the LPNs to really communicate that. Also, for the most part, healthcare aides are not allowed to chart. And so even if they have observations, it doesn't really get captured. And so one idea is if we have truly collaboration, first of all, there should be more trust in the team. There should be a higher comfort level for all providers to actually speak up and share their observations. There should be a greater capacity by team members to actually listen to all levels of providers and include that information in decision making. And so I think that's a very concrete example how we might be able to prevent pressure ulcers just by better communicating between the different providers. Another example might be interprofessional care plans. You might find this shocking, but they don't really truly exist. There is no care plan where everybody, all the providers document in the same system. And so that quite often leads to gaps and miscommunication, which can then lead to some adverse events.
Yeah, and a good example of that is the ICU daily goals sheets, which are interprofessional care plans.
Sorry, can you speak more to that?
Oh, sorry. In some places in our hospital anyway, the ICUs all have a daily goals sheet, which is used by all members of the team together to plan the short-term and the medium-term, sort of course of care for the patient.
That's right, yeah. And I think that's sort of equivalent to the interprofessional rounds that I alluded to. But as I mentioned in the presentation, the quality of those interprofessional rounds is not always great. What we have found is particularly around decisions that are being made, that there's a lack of accountability. So people assume that someone will follow up on the decision made, but it's not always explicit. Who will follow up and by when and how it's being reported back. And in some events, this has led to, adverse events or miscommunications.
Yeah, I guess one of the issues with these care plans is exactly what you said. That is, who follows up on what and who understands what's in the plan. And it's almost as if you need a medical editor, so to speak, to create a literate, brief, succinct plan with defined branch points for accountability. Because just saying that they don't follow up and therefore they're not being accountable, they may not be understanding what is in this morass, as it often becomes, of a care plan. So the design and use of those care plans, I think, is especially important. We don't have people doing that kind of medical editing sort of function because no one has time or really perhaps the skills to do it. Brenda.
Thank you, Esther. I was wondering in your model, and this relates to the care plans because some of us have plans that are actually for the patient to show where they're at, if it's an inpatient admission with a particular diagnosis and where we expect them to be over time. And you have patient experience under quality of patient care, but I don't see patient and family engagement in the care. And I think it is different than just their experience, but how much they co-produce with the healthcare team what they want and what their expectations are.
Yes, that's absolutely correct. And I didn't want to imply that this is a comprehensive list of all the potential outcomes, so they really meant as examples. So patient-family engagement, absolutely. We would typically link this to the patient experience. So if the patient is really part of the team, if they're being engaged in the conversation, in the decision-making, if they're receiving the right information, the education, and not just sort of getting information around the medical condition, but also the psychosocial environment that needs to be addressed. I think for the most part, this is reflected in some of the patient experience surveys that are being distributed to patients. But that's an important point for sure.
Maddie Schmidt.
Hi, Esther. Maddie Schmidt from the University of Rochester. I started my talk today with the importance of definitions, and I'm responding to your comment that the categories that we put some of these things in don't matter. I'm reflecting particularly on the quality of care component and the fact that patient safety outcomes in the prevention of adverse events often exist in tension with more positive indicators and the need to keep those separate. And a good example is falls, because we want to, from a prevention side, prevent falls, for example, in the hospital, but we know that the best way to do that is to keep people in bed all the time. But we also know that something like that generates its own consequences that are negative from the point of view of deconditioning, which would be a positive indicator, right? That if we had people move through the hospital experience and didn't decondition, their health outcomes would be better. So I think we need to pay attention to the tension existing between patient safety outcomes and positive quality indicators.
Sorry, I'm having a bit of a hard time understanding you. So can you just summarize the question? I think I got most of it, but your actual question?
The question is, how would you?
I have a big echo in your voice.
I'm sorry.
My apologies.
Let me try to move back. Is that better? Is that better? Maybe I was
Yes, it
standing
is.
too close. I think rather than looking, what is your thoughts about looking at these indicators separately versus in combination with each other?
Absolutely. I mean, these are just meant to be selected outcomes under the bigger umbrella of quality of patient care that one could look at. I'm not trying to imply that we need to look at every single one, giving, it has to be fit for the context. You can look at them separately, you can look at them bundled. I don't know. The way I grouped it might have been somewhat arbitrary. From the practice perspective, the quality of patient care indicators, the way I have them in terms of adverse events, patient experience, patient sort of falls, whatever falls into there. These are part of our standard reporting that we need to do. And there is a strong quality improvement component to that. So a lot of the initiatives are really targeted to improving those particular indicators, and not so much per se the patient outcomes. So it is really the assumption that those quality indicators lead to the better patient outcomes.
Hi, it's Jill Thistlethwaite from Australia. I've read a lot of your work with the CIHC, so it's nice to put a face to the name. I was just interested in your comments about doing more observational research to correlate collaborative practice that people say they're doing with what actually happens in the clinical setting. A friend of mine recently finished a PhD in Sydney where they observed what was happening in emergency departments in several Sydney hospitals. And one of the things that always sticks out in my mind from her data was the 94-year-old lady who was in the emergency department for most of the day and had 65 separate encounters with health professionals during that time, none of whom spoke to each other. And the 94-year-old lady actually pointed that out to them. And I just wonder if what sort of observational research you would be thinking of, because that kind of data is very powerful.
Yeah, I mean, observational analysis is not necessarily our area of expertise. I'm aware of some of the methods that have been used. I think it's actually reasonably tricky to do good, reliable observations. We have been involved in a sort of a interprofessional education research initiative that used simulations around interprofessional competencies and clinical scenarios. And we acted as some of the observers that we then had to do sort of a rating of the behavior that was displayed. And it turns out that it's quite the challenge to get good inter-rater reliability in terms of observations. So I think the key is really to define what is it we're looking for. What would we really consider as exemplary collaborative competencies or display of collaborative practice skills, and how would we rate that on a scale? So what is a 0, what is a 1, what is a 5? And it requires a lot of conversation upfront discussion, sort of observing, rating, validating to get a consistent approach to rating. The other approach is more the ethnographic approach, where we just go in and we observe and then reflect on the observations, which I believe Scott is doing quite a bit of that, so he might be able to speak more eloquently to this particular approach.
I would just end with a question, Dr. Suter. You've given us a nicely organized approach to thinking about a variety of different outcomes, largely quantitatively based, but in the discussion we've talked a little bit about narrative, and one could throw in realist evaluation and other forms. But the real question is, which of these outcomes are most potent, might be the right word, in getting the attention of people who run the health systems. And you work in a public health system. Your continued existence is dependent on capturing the attention of the leadership of that system, I presume, as same situation many people are in. Have you given any thought to a hierarchy or ranking of what's most useful, almost from a media perspective, but with leadership, not necessarily with the public, although I guess one could ask the same question about the public ultimately, because that would be with political leadership, which represent the public. But have you given any thought to, what would you recommend, if you can at this point? What are the top 2 or 3 things or approaches that you might recommend? Or is that not something?
The short answer would be anything that really translates into value add. That could be, money saved or better quality. I know there's a lot of attention on adverse events and safety indicators. So if there is a real means to demonstrate the reduction in those events, because they're costly for the healthcare system. The other area that I mentioned is the human resources outcomes. So if we can demonstrate that we actually can increase retention, reduce absenteeism in the workforce through collaborative practice approaches, then I think that's a big win. Again, it's hugely expensive because sick people have to be backfilled. There's a lot of overtime associated with that, which really takes away from the resources that could be invested in other parts of the healthcare system. So for me, that would probably be the top 2 areas.
I think those are excellent examples, and the question in general that I phrased is something that I would ask the committee to think about a lot in its thinking about this, because we can come up with all sorts of fancy research tools and kits to get at some of these very interesting questions. But unless they have impact on leadership or the public, they're probably not going to be very helpful for us. And I think you framed that just beautifully for us. So thank you very much for your time. And with that, I think, unless there's any comments from the remaining stalwarts in the room, we are adjourned. But the committee can't go anywhere. It has to follow Patricia to a secret location.